Hello everyone, I am Salim Iqbal from Media 9 Network and you are watching India's first doctor-oriented show, Doctor Opinion. And opinion really matters. Today we will discuss about the stillbirth, and for this we have a very renowned personality from the health fraternity, Dr. Surekha Jain. Welcome to our show, ma'am.
Hello.
Ma'am, first a small introduction about you.
Okay. So, friends, I am Dr. Surekha Jain. I am a gynecologist and obstetrician practicing in north of Delhi since last 35 to 40 years. And I am owning a own hospital with the name of Jain Multi-Speciality Hospital. Also a senior visiting consultant to Fortis Shalimar Bagh. So, friends, today's topic is stillbirth. As the name suggests, still means the one who doesn't move, and birth is a childbirth. So stillbirth means a dead born baby, and such a baby is a real catastrophe both for the parents and the doctor. So friends, you know, if a mother has a stillbirth, what she must be going through. So by the definition, if we see in India, it is any child born after 28 weeks or at 28 weeks of gestation or pregnancy, which is a non-viable or dead, and its weight is around 1 kg, and if weight and date of the mother is not of the child and the date of the birth is not known, then we can measure the length of the fetus from the head to the hip. If it is more than 35 centimeters, it is a stillbirth baby. Why we are talking about 28 weeks and the weight and the length? Because before this is not called stillbirth, this is called missed abortion or intrauterine death also, we can call both of them. So now we know what is stillbirth. So the second question arises, why does it happen? There are so many reasons why the stillbirth occurs, and we can easily classify them into different categories. First of all is mother's causes. So the mother's causes are, if the mother is of older age, like more than 35 years, and if she is obese or undernutrition, or you can say overnutrition, if she is more than 30 or 35 BMI, kilogram per meter square, this is one of the risk factor to have a stillbirth. The second is all the maternal health conditions, like if the mother is suffering from diabetes, or she is again having hypertension, or she is having coagulation disorders, or if she is suffering from the some infections like viral infections of rubella, cytomegalovirus, herpes, Zika virus, parvovirus, and parasitic infections like toxoplasma, and then bacterial infections, especially streptococcus beta hemolyticus. And the mother, if her environment is not good, if she is smoking too much, or she is an alcoholic, or she using some drugs, then the chances of stillbirth in this particular female are much higher. There are certain other diseases which make mother more prone to have a coagulopathy. Certain autoimmune diseases, if you can understand, where your body becomes your own enemy. Now the second thing comes about the placenta and the umbilical cord. We very well know that the mother's nutrition goes to the fetus which is growing in the uterus. And how does it happen? It is through placenta and the umbilical cord. So certain problems or abnormalities of placenta, like if the placenta is situated below the normal situation in the uterus, here the placenta cannot give good nutrition to the baby, and it keeps on bleeding off and on, and that is how the baby can die at any time. Second condition, where the placenta is normally situated but gets separated from the uterus, this is known as abruptio placenta, and it usually happens in some trauma to the abdomen of the mother, or if the mother is having very high blood pressure.
As one question, what is some common risk factor for stillbirth, and how do you assess and manage this risk during pregnancy?
See, as we have already mentioned, two of the categories, one of the mother's problems and second of the placenta's problem. Then there are certain problems of fetal itself. Fetal itself means if by chance when the ovum and the sperms are getting united to fertilize, at that particular time if something happens, like if the mother is exposed to x-rays or some harmful chemicals, then the baby can have a congenital, means inevitable condition where it is abnormal. Such babies, they also have not very long life in the uterus itself. They can die before 28 weeks or they can die after. So this is also one of the condition where the mother can have problems. And lifestyle factors we have already talked about, and again I can say this is one of the condition. Even the multiple pregnancy, twins, and here also the chances of stillbirth are higher than the normal single pregnancy, twins or other multiple pregnancies. Poor perinatal care, if the patient is not attending to the doctors properly, if she is having any problem. Genetic factors, if the mother is already having some genetic factors from her heredity, she can pass it on to the baby. And sometimes you can understand, because the baby is not totally of mothers, he gets half from the mother and half from the father. So even if the mother is sometimes having some genetic factors and the father is healthy, the baby can go on. But if both father and mother are having genetic problems, then the chances of having stillbirth are very high.
What are the typical diagnostic procedure or test you perform when evaluating a potential stillbirth case?
Okay, so first of all, how to say that this baby is stillbirth? So first part of the question, and the stillbirth is assessed by when the patient comes to us at around 28 weeks and suddenly she says that my baby is not moving. And if we auscultate or we listen to the baby's fetal heart, whatever devices we have, and we are not able to listen to the fetal heart of the baby, then we can see it under ultrasound. Ultrasound will show us that there is a baby who is not moving and who doesn't have any cardiac activity. That is how we confirm the stillbirth. And once we confirm the stillbirth, then our duty becomes to get rid of it as soon as possible. Why? Because however, if we leave it as such, it can deliver by 3 weeks, 4 weeks by itself. But if we leave the dead baby inside the mother, there are certain toxins which are released which can harm the mother and which can really create trouble for the mother. So once we diagnose stillbirth, we want to get rid of it. And the second part, if we suspect, how do we suspect? If we suspect with so many diagnosis tests and the history that this mother is at high risk of having a stillbirth, how do we proceed? We proceed right from the time when the mother conceives. We start taking a history of similar episode. She had stillbirth previously. If she has already delivered a stillbirth, we take history of when she had stillbirth, what was in that particular pregnancy. If she had some hypertension, had she had diabetes or insulin injection, or she was diagnosed with an autoimmune disease, and what was diagnosed, what was the diagnosis at that particular time when she had stillbirth. And once we know high risk, we start her management from the first visit itself. We get her lab investigations done first of all, hemogram, blood sugar, her kidney function, liver function, her hepatitis B status, her HIV status, hepatitis C status, all infections, torch profile. This is a complete panel of infections which can cause stillbirth, so we do torch panel. And then as she approaches around 11 to 12 weeks, the first trimester anomaly scan, which is a highly technical scan which is done by the fetal medicine specialists who are expert in doing the ultrasound. They are very helpful to us. They can diagnose very early at 11 to 12 weeks whether this child is going to develop fully or having some problems of its growth. Along with this test, we get some blood tests done which are known as double marker, and together combined test gives us a assurance of around 98 to 99% that this baby and this mother is going to have the smooth pregnancy outcome. So see, this is a very good test. And then In the second trimester at 20 weeks, again we do a fetal anomaly scan where we can diagnose all physical major problems, like if there is absent brain, or if there is absent lung, or absent kidney, or absent stomach, or any major physical problem can be detected which are not compatible with life and which will go into stillbirth. But there are certain minor problems also which can be parents' choice whether they want to continue with them or not, like having small fingers or just attached fingers, syndactyly. It is known as syndactyly when the fingers are joined, or a talipus equinovarus, which is known foot is rotated. These are not, they are correctable. They can be corrected after delivery, but we can come to know in the second or first trimester about them. Then along with this we do many testings, like again in color Doppler at 30 weeks, where we can come to know whether the blood flow to the fetus from the mother is proper or not, or from the mother it is fine or not, or whether mother is giving good blood but the fetus is not receiving. So we highly technically find out where the cause lies and get it corrected if possible, or if it is not possible, we can take out the baby at 32 weeks, 34 weeks, 36 weeks, 38 weeks, whichever weeks of gestation allows us to go up to. If baby is delivered at 32 weeks and alive, we can always put the baby into the nursery and then take care of it. So this is a very good sort of management, that the baby is taken out alive before it is a stillbirth.
So, one more question, ma'am. Can you describe some potential complication or medical condition that may lead to stillbirth, and how you address there during a parental care, ma'am?
Again, this is the same. If the mother develops high blood pressure, high blood pressure means if the mother is having high blood pressure, her blood vessels are narrowed down. So the two uterine arteries, if they are narrowed down and giving not a proper flow to the placenta, then the placental insufficiency will occur. This insufficiency will show as the fetus growth restriction, which we call as intrauterine growth restriction. So the growth restriction will occur, and if we do not correct it, if we do not correct the growth restriction by medicines and other medical managements, then the baby will die in utero. Secondly, diabetes mellitus. Diabetes mellitus also have its own effects, and the baby can die any time in the utero. Third is thyroid. Hypothyroid is very notorious. Anytime it can cause death of the fetus. Then there is a condition which is known as ICP, intrauterine cholestasis of pregnancy. It is a condition where the gallbladder secretion, which is bile, gets collected into the liver and gives bad toxic effects to the baby. Here also the baby can die from 32 weeks to 38 weeks anytime in the uterus. And what happens, you have sent the mother having ICP, not corrected, and patient goes one day, today she has come, we have listened to the fetal heart, it is fine. Next day she comes and says, madam, mera bachcha nahi ghum raha. So this is a very pathetic condition. We have to find out the condition, which we can easily find out with the symptoms and the investigations. So we can save the baby. If we know that this baby is going to die within another 24 or 36 weeks, 36 hours, we can always take out the baby and put in nursery. So if we are vigilant, if our patient is listening to us and is very particular about attending the doctor the time the doctor has called them, then we can always save stillbirths. But the doctor and patient has to work in coordination. The patient also has to be very cautious that she has to go and attend the doctor.
Right. Last question, ma'am. Can you share any personal experience and memorable cases involving stillbirth that have influenced your approach to patient care?
Yes, I'll tell you one patient. I'm working in Shalimar Bagh, and this patient was from Adarsh Nagar. She had 2 stillbirths and no live baby. This time she was coming to me, and around 34 weeks she started having severe itching in her body. This is a sign of ICP. Cholestasis of pregnancy means bile acids get accumulated in the body and they give severe itching to the patient. We investigated her and found the bile acid, which was very much raised, and she needed immediate admission and supervision. We asked her to do that, but she didn't. And in the night at around 12 o'clock she came with severe itching. We admitted her. We tried to manage her. In midnight and at around 2 a.m. her fetal heart became just 70-80, which one should be 140. We immediately did a cesarean section to her, and we could deliver a live baby, which was just kept for 1 week in the nursery, and the baby is still very fine. So the message is that doctor should be vigilant and the patient should be following your instructions. He should comply with the instruction. That is very important. Sometimes patients take it very easy. Another incident I'll tell you. My patient was almost 39 weeks, and nowadays we recommend our patient to deliver by about 39 weeks, but she was very particular. She said, no, my family says you should complete 40 weeks, and if you do not complete 40 weeks, we will not let you admit and get anything done. It was Sunday and Saturday, and in between it was Sunday. Monday she came and she said, my baby is not moving, and to our surprise it was a dead child. And when we asked her, why didn't you come on Sunday? She says, my family said sometime bachcha so jata hai na, don't worry, we'll go tomorrow. So these are the things we always explain to our patients, that if you want to wait, then you have to count your fetal movements every day. Every hour, every 2 hours, 3 hours, your baby should move. If it is not moving, please report in time. Then only we can do something. If you bring with a dead baby, we cannot do anything.
Right. Thank you so much, ma'am. I think it would be very helpful to our viewers. Thank you. Thank you so much.
It's my pleasure. Thank you.